behalf of Aditya Eye Hospital, welcome our chief guest speaker, a world-renowned vitreoretinal surgeon, Dr. Rizzo Stanislaw. I'm very happy and honored to welcome him to today's function. I also welcome all the guests, my colleagues, for sparing a few hours of their valuable time to come here and participate in this function.
Excellent. So, what is the need of an artificial vision today, an artificial vision prosthesis? You know that we have different diseases of different layers of the retina. Today we will talk about the disease of external layers of the retina, in particular about the retinal pigment film disease and of the photoreceptors of the disease. Today we have 30 millions in the developed countries with these problems without retinal disease, and 10 millions only in the US. Unfortunately, we have only epidemiology data only from the US. And 1 million of these people are completely blind. For example, regarding the retinitis pigmentosa, we have we estimate about 1,200,000 people worldwide and 100,000 people only in the US, of course, different stages of the illness. Today we test many strategies for retinitis pigmentosa. For example, the intravitreal growth factor, the gene therapy, the vitamin A supplementation, the famous Cuban therapy, ozone therapy and stimulation. But we can propose today a true therapy that for the first time a very effective treatment, the visual prosthesis. This is the holy ground for every ophthalmologist, and we can have a different approach for this problem. For example, a retinal approach, we show you today this approach. Subretinal approach, for example, the German implant, the retinal implant prosthesis, the optic nerve prosthesis, and also the cortical prosthesis. In fact, we can stimulate the visual pathway at different levels, ocular level, optic nerve level, and of course also the cortical level. This, for example, is a memory. This is a famous Dobell implant. It was a cortical implant. This was the first and the only eye patient operated by Dobell. Dobell was a Swiss surgeon. You see the cable coming from the skull of the patient, and this cable is connected with the electronic spectacles. Unfortunately, this patient died 1 month after the surgery for a complication, for a brain infection. They also, 2 months after the surgery, died also from there, like was defined in the books. The principle underlying all retinal prosthesis is replacement of photoreceptor function, of course, in patients with retinal degeneration, dystrophic retinal degeneration. It is the beautiful slide about our retina. You see the photoreceptor lights. We can stimulate the diagonal cells, the bipolar cells, and the ganglion cells from supraretinal approach, apretinal approach. Ideally, the supraretinal approach is more physiological because, of course, it is under the retina where the photoreceptors were. But in this patient, the photoreceptor layer is completely destroyed. For this reason, this difference between epiretinal and supraretinal, I don't think is very, very useful, because you have to stimulate with this prosthesis these spinal cells, bipolar or ganglion cells. In fact, see that you look at the difference between a normal retina with all these layers, these photoreceptor layers, the ganglion cells. Look at the retina of photoreceptor patient. For example, this is completely subverted. The photoreceptor layers are larger, and you see that some photoreceptors send the axons, like ask some help to the ganglion cells. Today we have many groups for research. For example, the Belgian implant, the Japanese implant, 3 groups of research in the US, 1 group in Japan, 1 group in Germany. But I'd like to present you some experience about these three groups, because they're only groups who published something on peer-reviewed journals. The only groups we can examine the results. The optobionics from Chicago, the subretinal implant from Tübingen, retinal implant project, and the second side, the IRIS 2 project from USC, from Marco. This was the first implant, the first subretinal implant, this optobionics from Chicago. This is the inventor is Cho from Chicago, but the surgeon was Keith Parker. I think many of you know well Keith Parker is a great surgeon in the US. And this the implant is 400 microcentimeters implant. This is completely subretinal with 5,000 isolated macrophotodiodes. This was the surgery. The surgery was not very difficult. It consists in creating a bleb, subretinal bleb, open a little bit the retina, and implant subretinally this subretinal implant, this prosthesis. You see, the implant is far from the macula, because they thought that maybe stimulating the retina, also from the macula, they can obtain some results. This was the 6 implants implanted at the time. See, this the implant is from the right to the center of the macula. This was the optical coin tomography of the implant. You see the shadow effect of the implant, of course, was metal. You see this implant with the normal thickness, the shadow effect of the implant. And they published this good result. If you see in green there are a number with patients who obtained a good result compared with preoperative. You see 0.2 compared with 0, the red number was where the patient had the worst result. The second implant I'd like to present is German implant. This implant obtained a CE mark 2 weeks ago. The father of the implant is Professor Zen from the University of Tübingen. It's a completely different project. It's 500 microphotodiodes, completely under the retina. But the implant has to be connected from an external source of power. The surgery is a little more difficult. It creates a retinal detachment, and from external part of the sclera, the implant goes under the retina and under the macula. This is the position of the implant, also in this case, apart from the macula. You see the implant with the OCT. You see the first 8 patients in the first clinical trial. You see, this is a difficult surgery because sometimes you can have some bleeding on the retina, causing in this case the visual acuity is very poor. It is the typical surgery of this implant. First they create a Kilon bubble in which attachment, then open the sclera up to the choroid, then they diatomize the choroid, and then they insert this slide, this giving to up to the macula. This is the subretinal space between the choroid, of course, retinal epithelium. You see there's the light, and then the implant follows the slide up to the macula. See, in this case, the implant is very, very well positioned. They published this result last year, but they had some problem. They had some problem with the biocompatibility of the implant. For example, in each patient, they have intraocular taper break. They have in some patients also the corrosion. So this implant demonstrates some problem with biocompatibility with the patient. I'd like to share with you my experience with this system. This is the Argo 2 system. Our system is composed by a glass with 3 megapixel camera in the center. The 3 megapixel camera is connected by a cable with this video processing unit. The patient wears this processing unit on his pocket. It has 3 filters, some programs the possibility to modify the brightness, the zoom of the image. The video processing unit elaborates the image and sends the electronic signals to internal part of the implant. This internal part of the implant is an antenna